I'm going to fast forward to 2012, and the reason why I say 2012 is because I'm going to use this framework on the clinical definition of ARDS to talk about pathophysiology, all in 15 minutes, okay? So, I think we know that the five main features of ARDS are the ones that you can see over there. So there is non-cardiogenic pulmonary edema. The lung volumes are reduced, as we've seen from the previous talk. The compliance is reduced. There is an oxygenation defect and a poor CO2 elimination. And that comes from that, it's all encapsulated in this clinical definition. And I think we're going to go through some of these features to talk about the pathophysiology. And one is the timing. So bear that in mind because it's very important. We'll see how that links to the pathophysiology when we say it's less than 1 week of a known clinical insult. Keep that in mind for a second. Then the second, the following ones, so the chest imaging, the origin of the edema and the oxygenation, has everything to do with an inflammatory pulmonary edema. So when we say about the chest imaging, it has to be bilateral opacity because it has to be consistent with a diffuse lesional inflammatory edema. And clearly the origin of edema has to be inflammatory, therefore non-cardiogenic. And then there is an oxygenation criterion there that says CPAP greater than 5. We've seen the previous talk from Professor Quintel when he said that the first description, which is now 50-year-old, almost exactly, said the thing that this patient had was response to PEEP. So we want to put a PEEP criteria greater than 5, and then based on the oxygenation defect was mild, moderate and severe. Now why am I putting that there? Because there has been a recent modification of that Berlin definition, which is particularly for the resource-constrained places, like for example this is in Rwandan population, the Kigali modification, which sometimes doesn't have to be in Rwanda, but it can be in our own place when we don't have available, for example, CT scan, or if there is any place where the PO2 might not be readily available. But you can see on your left-hand side, the second column, the Berlin definition, and the modification, the Kigali definition on the right. But essentially, one is using the SpO2 instead of the PaO2, and that's a new criterion, so less than 315, and the use of chest ultrasound rather than CT scan. And that's been really helpful because with this definition, they could identify a 4% of patients who have been admitted to the hospital satisfy this criteria. And only 1 in 3 were admitted to the ICU, but these patients had 50% mortality. So very much what we would understand as patients with ARDS. Now, do you remember the first criterion was less than 1 week of a known clinical insult? And this is what we recognize as the known clinical insult. We know there is a direct pulmonary injury, which we call it pulmonary ARDS, and an indirect. And as the previous talk was mentioning, we mustn't forget that we're adding a secondary insult through mechanical ventilation, and that's due to the cyclical mechanical stretch. But the reason why the less than 1 week is important, because there are lots of other conditions that here we call ARDS mimickers who lack the common risk factors. And one of the common risk factors is that these patients have a much longer time to developing ARDS, sometimes weeks. They present with moderate to severe ARDS rather than mild. The greater mortality, 66 versus 53, more steroids used, more NIV pre-mechanical ventilation, and they tend to be single organ failure, so the lungs, and that's the cause of death rather than shock or extra organ failure. And you can see there at the bottom the split between autoimmune, drug-induced, idiopathic, and malignant. Now, going back to the 5 features, the first one is the non-cardiogenic pulmonary edema, which leads to an oxygenation defect. Now, I tried to simplify that into a cascade, which basically leads to the first phase of the ARDS pathophysiology, which is the exudative phase. And so you can see, if you follow from your left to your right, you can see there is a first injury, immediately followed by an exudation, which leads, previous one, to an innate cell-mediated immune damage. The alveolar macrophages, which are the most common cells in the alveoli, once they meet the inflammatory pathogens through the pathogen-associated patterns or the damage-associated patterns, they transform themselves in something very highly inflammatory called M1-like macrophages, and they lead to neutrophils accumulation and inflammation. And this inflammation affects endothelial cells, who release a lot of mediators that now we can measure in the blood. And the reason why I put that there, because it's important. I'll show you how certain patterns of these mediators can determine the response to clinical and ventilator management. So the endothelial and the epithelial cells, which leads to apoptosis, which leads to reduction of surfactant. The ion channels, like the sodium and water channels, are reduced. Therefore, there is accumulation of fluid, which leads to interstitial and alveolar flooding or protein-rich edema. And from our clinical point of view, what it means is the lung becomes heavy, becomes the shunt fraction, so the amount of blood that goes through the lungs that is not exchanging oxygen and carbon dioxide increases, therefore hypoxemia. The lung becomes smaller, and therefore the compliance goes down. In addition, the endothelial cells produce some tissue factors which clogs some of these small capillaries with microthrombi, and increase the dead space, and that leads to hypercapnia. So when we look at this picture here, chest X-ray of different severity, we can see that the lung edema, here measured at extravascular lung water, increases with increased severity of ARDS, and the vascular permeability of the lung increases, going from mild to severe ARDS. But what does that mean in terms of the bedside? You can see on your right-hand side that as the water increases, the lung weight increases. As the lung weight increases, there is more collapsed, non-aerated tissue, but also means there is a greater potential for lung recruitment. It means the increase in the PEEP will increase aerated lung. And this is from the validation cohort of the definition that I showed you earlier on. If you can see on your left-hand side lung weight, and here's the percentage of shunt in blue, you can see the lung weight, this is in grams, so 1.3 kilos, increases with severity. And as the lung increases in weight, so it's full of edema, the shunt fraction increases. And you can see here, in severe ARDS, 40% of the lung is shunt. 40% of the cardiac output shunts ventilation. What it means that above 30 to 40%, this is refractory hypoxemia. So it's not easily correctable by increasing FiO2. So that's why mechanical ventilation becomes important. And here you can see, this is a nice paper which was published now in 2013. You can see the physiological shunt here, or the CT shunt measured with CT scan, and is proportional to the PF ratio. And here, that's why there's the link between shunt and oxygenation. And there is a lookup table here on your left-hand side, but just for the ones at the back, I've picked up 3 points where the mild, moderate, and severe, and you can see the amount of shunt that corresponds to these 3 levels of severity. It's about 20% for the mild, about 33% of shunt fraction for the moderate, and greater than about 50% in the severe. So you can see there how PF ratio relates to shunt fraction. Now, do you remember I showed you all those molecules in the previous slides? And I think this is a very interesting series of papers where they show that there are ARDS subphenotypes, or you can call it endotypes. I've redrawn this picture, just I think it might be a little bit clearer, but you will tell me. You can see on your right-hand side here on the y-axis things like interleukins. Some of the molecules I've showed you earlier on, but other things like PEEP, respiratory rate, age, BMI, PF ratio, bicarbonate. And what this analysis, using this latent class analysis, has demonstrated, there is clearly a pro-inflammatory phenotype called phenotype 2 with high IL-6 or inflammatory markers, and you can follow there low bicarbonate. And there is a hypo-inflammatory phenotype. Now, why should I care so much for us clinicians at the bedside? Because their response to fluids and PEEP is very different. So you can see the hypo-inflammatory phenotype, they do better in terms of mortality with lower PEEP and with liberal fluid management. Okay? Whereas the phenotype 2, which is the pro-inflammatory, so these are the patients who are hypotensive, a lot of extra pulmonary failure, and they tend to be more septic, they benefit from higher PEEP and a conservative fluid management. Okay, so that you can see how the pathophysiology at molecular level comes together at the bedside in deciding what PEEP and what fluid management we should administer. But we have gone through the first phases of ARDS in terms of the exudative phase, and then it becomes a proliferative or repair, because sometimes the proliferation and the repair, they go together. And what is characterized this phase, which is the second phase, is a provisional fibronectin matrix deposition. And do you remember that I was talking about these very pro-inflammatory M1-like macrophages, where they start transforming themselves again through other factors into a M2-like macrophages. And this, they produce other factors, growth factors, that can repair the endothelial cells and the epithelial cells, so they can start producing surfactant again. The ion channels are restored, there are some aquaporins. Essentially, all the fluid that has been accumulated over the first phase, it gets removed. And as a consequence of that, the edema is reabsorbed, and the lung weight goes down, the shunt goes down, compliance goes up. And I put there compliance lung volume interchangeably. And those markers, which has been associated with ARDS outcome and subtypes of ARDS, go down. And this is a marker of resolution. So if you can see the time course, you can see the exudative phase goes down over time from ARDS onset to day 28. But the proliferation continues to go up. And the fibrosis goes up as well. Notice that not all patients will develop fibrosis, fortunately. And the other thing to say is that the percentage of lesions that you can find in ARDS as fibrosis is minimal or negligible in the first week. And you can see that a little bit better, I think, in this histograms, where you can see the first week, a very little proportion of fibrosis, but you can see that the pulmonary ARDS tends to have a greater percentage of fibrosis compared to the extrapulmonary. So the pancreatitis, the sepsis, the other origin of ARDS. And this increases over time. And once DAD, which is diffuse alveolar damage, was considered to be pathognomonic of ARDS. We now know that it's probably not necessary to have DAD to classify ARDS at histological level, but probably DAD subclassifies ARDS into a more severe form. So you can see there are a group of factors there, and you can see that patients who have DAD, they tend to have a greater severity. The PF ratio is much lower. The driving pressure, as we mentioned before, much greater, 28. Compliance low. They tend to be single organ failure and therefore die of hypoxemia as opposed to shock, where it's more common in the non-DAD, and they tend to be late rather than early. So the last two things is reduced lung volume and compliance. We've heard very brilliantly earlier on, Professor Quintel has shown a really nice CT scan, which essentially demonstrate two things. They demonstrate that the compliance is proportional to the inflated lung volume, so what is called the baby lung. And I put there that the ARDS lung is small, and therefore baby lung. But if you normalize compliance per liter of FRC, that's normal. That means the normal lung, the baby lung, is structurally normal, it's just very small. And also that the baby lung is a functional entity, it's not anatomical. And that was shown by proning position. You can see this is a CT scan in supine, and you can see that the baby lung is up there in the non-dependent area. And all this is collapsed by water and gravity, a superimposed pressure. But during prone position, the baby lung is reverted. So that gives an idea that the baby lung is functional, and then we heard about the sponge model. So with the sponge, the water follows gravity. But it doesn't stop there. The lung is not only small, but it's also inhomogeneous. What does that mean? It means that if we calculate the FRC as a whole, will give us an idea, or the tidal volume divided by the FRC, which is the strain. But this strain is not distributed in homogeneous fashion. You can see here that there are lung units which are normally inflated, and therefore the same tidal volume will produce a normal strain. But there are some other lung units that are very small, collapsed, where the same tidal volume will achieve near total lung capacity. And in some other areas, they are at rupture. What does that mean for the mechanical ventilation? What it means is that if we decide what a safe transpulmonary pressure is, some of these areas, the stress or the stress at this level can be multiplied by 4 times if you look at the in silico model, 1.9 times if you look at the CT scan model, and 1.6 times if you look at other experimental model. So if we look at some calculations, for a transpulmonary pressure of 25, the local pressure at the interface between these two units, for example, may be 116 centimeters of water if you go with the MEAD model, 47 centimeters of water if you go with a sort of Gattinoni CT scan model, or 40, but it's not 25. Okay, so that's important because we'll need to know what the strain at the local level is in mechanical ventilation. And the last bit has to do with CO2 elimination. So we know that the hypercapnia in ARDS is due mainly to 3 things: hypoventilation of some units, dead space, we've looked at microthrombi and a reduction in ventilation, and shunt. So how does that shunt produce carbon dioxide, increase in the arterial side? So if you follow this cartoon, you can see on your left-hand side, this is the mixed venous CO2. A part of the CO2 will go through the lung, will get exchanged, therefore it will be similar to the alveolar CO2. But some of this, a quote of this, depending on the shunt fraction, will bypass gas exchange and will mix with the alveolar CO2, and therefore the arterial CO2 is a mix between the alveolar CO2 and the central venous or mixed venous CO2. And the proportion of these two values will depend on the shunt fraction. So we've looked at, in the history, we've thought about permissive hypercapnia, where we should allow it, therapeutic hypercapnia, where we actually should encourage hypercapnia. But these two studies, one is a bit old, which is 15 years old, in the New England Journal, that showed the mortality increases with increasing dead space fraction. So for each increment in dead space, the odds ratio of death goes up by 1.45. And this is new. There are two here I put down, but these are multi-center, thousands of patients in Spain and Australia and New Zealand. But essentially, I put there a graph for you where you can see the odds ratio of death with the PaCO2, and the odds ratio goes up by 1.8 to 2.9 times if the PaCO2 is greater than 65. And I'm going to conclude with that and say, think about the 5 causes or the 5 pathophysiological characteristics of ARDS, and think about how this will apply in your mechanically ventilated patient. And with that, I thank you for your attention.